All right. So thanks so much for joining me. Today I have Dr. Samira Farouk. She's a nephrologist at Mount Sinai. Any details I'm forgetting? What are some of your clinical, uh, credentials here?
So I'm a nephrologist. I'm also a transplant nephrologist. So I mainly see patients with kidney transplants, and I'm an associate program director of our fellowship at Mount Sinai.
Amazing. All right. So today for this video, what I wanted to talk about is sort of AKI, defining an AKI. And I feel like in the ED, we sort of have a general, we know it when we see it type of attitude towards AKI. Okay, creatinine's bumped, this and that. This is an AKI. But I sort of wanted to dive into a few of the details to really define how we go about making this definition, really get into the weeds for just a little bit.
Yeah, absolutely. And so I would start by saying some of these definitions that we have for acute kidney injury or AKI, or how we stage AKI, really are designed for research purposes. And so clinically, I think it's a bit more amorphous. That being said, the official definitions, which are really guidelined by KDIGO, which is an international kind of governing body for nephrology that periodically will come out with these quote official guidelines, would say that AKI is defined by a 0.3 milligram per deciliter increase in the creatinine, or 1.5 and a half increase over the course of about a week, or oliguria or urine output less than 0.5 cc's per kilogram per hour over the course of 6 hours. And so in the context of the emergency department, I think all three of those definitions can be a bit hard because, one, really hard to get urine output over that period of time unless somebody is recording that at home, which almost is never happening. Right. And two, the question of what is the baseline, because our definitions of AKI really arise from the baseline, whether that's an increase in 0.3 or increase by 1.5 times. Yeah. And so how do we figure out what somebody's baseline is? And it's maybe unusual for somebody to come into the ED having had blood work done about a week ago. Sometimes we do have that. If somebody is, just had a surgery, they're getting close follow-up, they actually may have had labs that have been done. And so we may be able to get a more granular trend of the creatinine, but other times we may not have blood work within the last 5 years even. And so I think in those cases, it can be a little bit trickier. And like anything in medicine, the key really is the trend. And so, if we see somebody presenting for the first time with no prior labs with a creatinine of 2, for example, there's no really good way to know whether that is a acute change or not. And so right. what we would do is really just follow that over time. And as nephrologists, we often get consults on the inpatient and outpatient side where, we have this kind of one time point. And so what can we do to really assess whether this is acute or chronic? And there are some things that we can do to try to differentiate the two. I'm not sure that those would be done in the emergency department setting.
Well, right. Okay. So let me just take it back. So just to define it, and I know these definitions, I could tell are pretty limited in what we can do with them and how we can make them. But technically, the definition is a rise of creatinine by 0.3 or an increase by, I guess, 150%. So 1.5 times. Mm-hmm. And that's over 7 days or
right. Yeah. So that's the official definition, is over 7 days. Again, I think these are definitions that are needed in the research setting when we're thinking about, including or excluding patients in clinical studies.
Right. Okay. And then urine output changing, or a decreased urine output for 6 hours, which, as you mentioned, in the ED, that's something that's going to be almost impossible for us to quantify. We don't even want to have patients in the ED for 6 hours if possible. So, and then I guess I'm thinking just an increase of 0.3 versus 1.5. It sounds like, the vast majority of patients would fit in under the 0.3 escalation versus 1.5, unless they happen to have a really low baseline creatinine, it sounds like.
Right. So the 0.3 it was not only an easier definition, I would say, to kind of quickly do, but also I would probably a more conservative definition. And I think now is a good time to, remind that, as creatinine rises, GFR does not, it's not a linear change in the kidney function or glomerular filtration rate. So for example, a rise of creatinine from 1 to 2 is more of a drop in the kidney function than a rise from 2 to 3. So if we have a 0.3 increase in somebody with advanced CKD, so they're going from, for example, 4 to 4.3, as a nephrologist, that's a bit less exciting for me than creatinine going from 1 to 1.3.
Oh, okay. That's great. That's good to know. And then you sort of alluded to it, but a lot of times what we see in the ED are patients who have, let's say we have a patient with prior creatinines. A lot of times they're fluctuating all over the place. For example, maybe the last time the person was there, the person was also having an AKI, or some, we see them going up and down. And do you have any advice on how do you go about clinically thinking about what their baseline is so that you can calculate what is above their baseline?
Yeah, so sometimes it can definitely be challenging to know what the baseline is. And oftentimes I will document in my notes that the baseline is and have a range because it's really hard to pinpoint one number. And so I would think about assessing baseline creatinine as you would any other baseline value. And so if I asked you what is somebody's baseline hemoglobin, it's been going up and down over the last couple of years, you would really need to look at the context of what was happening during that time. So were they having a GI bleed at that time? Then that is not their baseline hemoglobin. And so as much information as you can really gather from the medical record to understand what is happening. And so if you can see clearly that they've had an AKI and then it has come down, and see where did that really plateau. And so oftentimes when somebody has an acute kidney injury, they may not always return to their baseline. And so the baseline may change. And so now they have a new baseline. And so what I like to do is to really graph the creatinines, and most of the EMRs have that function to do that. And it really kind of helps to give you a, zoomed out view to see where is the plateau. And if you do that, so say, for example, if I have data for about 2 years, I can graph those creatinines and I can see the peaks. The peaks will be acute kidney injury episodes, and I can see where the creatinine has leveled out. And some people truly just have labile creatinine, not really related to acute episodes, but the creatinine just may go up and down. They may be patients that are more volume sensitive. They may be on diuretics. And so again, the context, I think, is everything. And the baseline may be a range, may not always be one singular value.
Sure. Okay. And then, the other issue I think we run into in the ED is oftentimes we don't have a baseline creatinine, or the creatinine we have is from like 3 years ago at some other hospital with no context, and the patient doesn't even remember going to the ED to get that lab value drawn. How do you go about assessing if you don't have, technically that definition is saying within 7 days we should have, that's how we would define it. So do you have any pearls on how we can go about figuring this out if we just have, say, no prior creatinine or one prior creatinine from a long time ago?
I think the key here is collecting as much collateral data as you can in the limitations of the environment that you're in. Obviously, if a patient is admitted, then that's a different story. We have more time, we can get more tests and things like that. I think one, putting the patient into context. So if this is a, young, healthy patient, no history of common risk factors for chronic kidney disease like hypertension, diabetes, and they're presenting with a creatinine of 3, that might make me think that this is some sort of acute event that has been going on. How acute, of course, we don't know. We would have to, watch the patient over time and see. Data that can be very helpful to collect would be urine studies. And so looking at the urinalysis, is there evidence of some sort of intrinsic kidney injury? So is there proteinuria or albuminuria? Are there red blood cells in the urine? Are there white blood cells in the urine? So that can give some indication of not necessarily chronicity, but that there is some signal that there is an intrinsic injury that is ongoing. The other test that
I
we
love
like
that.
to...
That's so basically, just to summarize that, it's like if you're not sure if this is an acute process or maybe this is chronic, this has been going on for 6 years and slowly worsening, maybe a urinalysis would help to make that differentiation. It's not 100%, but at least if you see something on the UA, that could indicate that something acute has happened.
Yeah, again, as you mentioned, chronic kidney disease, as it progresses, proteinuria can get worse and these other parameters can get worse. I think if you saw what we call an active urine sediment, and this is a new process for this individual, regardless of the age, that does warrant some more investigation. And the other test that we like to use in these cases where it's hard to assess if this is more acute or more chronic is the kidney ultrasound. And one of the reports that we often get from radiologists is a report of the echogenicity of the kidney. And when we find this report of, high echogenicity or, mildly echogenic or very echogenic, it is not clinically that useful except in this context. And so if somebody has a normal echogenic kidney, then that suggests to us that this is less likely to be a chronic process. If somebody has CKD for, X period of time, again, there's not a lot of data on this, then that suggests to me that this is a bit of a more chronic process. And so it's kind of like
So go ahead.
No, I was just, normal echogenicity is helpful in that it kind of points towards more acute process. Mildly echogenic or more, it could be acute or chronic.
Very interesting. Right. Okay. So it almost reminds me of sort of like an ultrasound of the liver, like fibrosis of the liver. Is it kind of a similar thing that we're looking at here?
Yeah, I don't think we exactly know why the kidneys are more echogenic, but yeah, that's definitely one analogy I think to compare to liver that works.
Okay. And when you say urine sediment, you mentioned that. So what are you're talking about protein in the urine, blood in the urine, casts in the urine, or what exactly do you mean by sediment?
So when we think about urine testing, there's really kind of two ways to divide it. One is the urinalysis itself. And so that can be done with a dipstick, which is the faster way, or the lab does what we call a more formal urinalysis. And so that will report several parameters. In the setting of acute kidney injury, what we're thinking about most are the presence of cells and the presence of or absence of protein. And so it will get a reading of, red blood cells, how many are seen per high power field, white blood cells, the same thing. And then the proteinuria will generally be more of a qualitative assessment. And so another, pearl that we would share often is that if you see proteinuria that is picked up on the dipstick, then the reflex should be to what's called quantify that proteinuria. And so that is because the qualitative assessment does not always reflect the severity of the degree of proteinuria. So as an example, you could have a 1+ proteinuria, but then when we quantify that, we have, 4 or 5 grams, which would be considered in the nephrotic range. And in that case, we might be thinking about some sort of glomerular injury that is ongoing. The microscopy is a separate part that is done by the lab, but they generally don't report everything that we might see if we perform the microscopy ourselves. And so when we get consults on the inpatient side for acute kidney injury, or even, chronic disease that has not yet been, differentiated, we have a microscopy lab, we take the urine, we spin it down for a few minutes, resuspend the sediment, and then we can actually take a look ourselves and confirm the presence of red or white cells that has already been reported by the urinalysis. And then also look for things like casts, so red blood cell casts, white blood cell casts, evidence of acute tubular injury. We might see those muddy brown casts that you learn about in medical school, which those are all real. I feel like in medical school, I thought that those were just fake things, but those are things that we actually see in real life that can sometimes be very helpful in making the diagnosis. Again, your microscopy is not something that I think needs to be done in the urgent emergency department setting, but that is kind of the next step in the evaluation of an AKI with what we call this active urine sediment. And so on the flip side of that, often what you'll find is what we call a bland urinalysis. So that means that everything, you look at everything is negative. So no white cells, no red cells, no protein, and there's still this AKI. And so that might point towards what we call this, pre-renal or volume related acute kidney injury. And so that's probably the most common cause of what you're going to see oftentimes in the emergency department setting.
Yeah, and we'll get into sort of that differential of what could be causing the AKI in a little bit, but I love these pearls that you're giving us. Is there any other advice you have for trying to distinguish what seems like maybe a CKD from an AKI when we're just sort of seeing the patient for the first time?
I think it's hard to other than trying to look at the imaging studies. It really, without any other data, we don't really have much else to go off of. And again, as I mentioned, even with the UA, it's not really going to distinguish chronic versus acute disease. And so just following the trend over time is the most helpful thing. And then also an assessment of what risk factors does this person have? And so, for example, if they have diabetes, how long have they had diabetes? And if they're, over 10 years, and that increases their potential risk of diabetic kidney disease. Do they have diabetic eye disease? And so the presence of retinopathy. One great way to ask patients about that is that, have you ever had lasers to your eyes? Because if they have had retinopathy, then the likelihood of diabetic kidney disease goes up as well, because the pathophysiology is very similar. It's a microvascular problem. And so longstanding diabetes, longstanding hypertension, those can be clues. And there are other more subtle clues that, again, probably are not going to come out in this acute evaluation, but some parameter that some nephrologists might use is to look for evidence of CKD-related metabolic bone disease. And so looking for evidence of secondary hyperparathyroidism. And so, the pathophysiology behind that, without getting into the weeds, is that you have these subtle elevations in phosphorus, and that ultimately leads to elevations in the PTH, and then over time can lead to problems with the bone. And so sometimes we might look for what is that PTH level, because if it is elevated, then maybe that could suggest that this process in the kidney has been going on for some time. Yeah.
Okay, that makes sense.
But again, you can have high phosphorus in acute disease, and then you can have PTH elevations in acute disease as well. So
right. So there's no straightforward, easy way to do this, but these are a few pearls. I think that's super helpful. I want one topic I feel like I have to talk with residents about this is like, maybe you could just talk about, some people can have a very low baseline, still have a quote normal creatinine, but in those cases, would you see that as an AKI?
Absolutely. I think great opportunity to talk about the many limitations of the creatinine. And, in nephrology, there has been a lot of discussion lately or the last few years about how do we actually estimate somebody's kidney function. And in short, there are a lot of limitations. And so I think one of the biggest changes has been, the removal of the race coefficient. And so that has left us with the equation that includes creatinine, age, sex, and I believe weight, and maybe some other variables are also in there. So the equations have been kind of evolving over the last several decades. And so creatinine, of course, is a main focal variable in these. And so we have to think about where does creatinine come from? And so we know that at extremes of muscle mass, and so people that are very, very muscular compared to those that are very frail, the creatinine will over or underestimate their creatinine. And so as an example, somebody that has very low muscle mass, their baseline creatinine may be, I think the lowest one I have seen is 0.2. And so for that person, they're coming in with a creatinine of 0.5 that is technically an acute kidney injury. And so, we're talking about not having baseline data. So you're of course going to miss that if you don't have that baseline information. So creatinine, again, we always have to use with a grain of salt. There are ways to improve that estimation or get different estimations by using something called the cystatin C, which also has limitations, but there are different limitations. It does not rely on having an assessment of or thinking about the muscle mass. And so there are some equations that use only cystatin C or use cystatin C in conjunction with the creatinine. Again, these are not things that you're going to be thinking about in the acute setting, but things that we might do in the outpatient side or once the patient is admitted for further evaluation. So
cystatin C, that's just a different enzyme that's sort of being excreted at a relatively steady rate that you can measure. Is that kind of what that is? Right. So it's another molecule that is cleared by the kidney. And so the limitation for that is that it is an acute phase reactant, so can be falsely elevated or decreased in some inflammatory settings. Interesting. Okay. And so there's a lot of, I think, energy that is going to be spent, in research and other things over the next, hopefully decade or so to try to come up with a better equation that is more accurate in the estimation. And just, for completeness, the best way to do this is to really get a 24-hour urine collection that is going to tell you exactly, or more precisely what that person's kidney function is, which again, of course, not happening in your world. Mm-hmm. Do those, if we are measuring urine output to try to assess an AKI, does it matter if the patient is getting IV fluids? I mean, obviously that would change their urine output. Are you just going for the best possible urine output you can get on them? Or are you trying to do it in a certain state where they're not eating, they're not drinking or something like that? I don't think that there's a lot of guidance about, the exact scenarios. My thought would be if I was in the ED would be to place a Foley catheter and just assess what is the hourly urine output. And if that, for a 70-kilo person, if that's less than 35 cc's per hour, then that is over 6 hours, that would be, considered an acute kidney injury. That being said, if you have someone that's coming in with an acute kidney injury with evidence of, volume overload, you would give them some sort of diuretic, usually a high dose loop diuretic, starting at least at 80 milligrams or 100 or something more than that, and then seeing what their response is. And that actually is predictive of how that patient's AKI will do. So if they have a good response to what we call this 2-hour stress test with loop diuretics and the urine output increases, and that is a better prognostic marker than if you give that big dose of diuretic and there's no change. That's great. Okay. Well, we'll come back to that managing AKI stuff. But last question in terms of making that diagnosis. Once, let's say we've made the diagnosis of AKI, and let's say we've also ruled out sort of secondary processes that are causing the AKI, whether it be sepsis, hypovolemia, heart failure, or something like that. If we see an AKI in general, is that a patient that ought to be admitted? Is that a patient that sometimes can go home? How do you think through which patients you would want to see on the inpatient setting versus which ones could probably go home, you could manage outpatient?
Yeah, I think the majority of the time, if you think that the creatinine is elevated enough from the baseline to be thinking about an AKI, the person deserves at least another creatinine value within 12 to 24 hours to look at the trend. So, for example, you have someone, there's no baseline data, you're not sure if this is CKD or not. You check the blood work the next day, creatinine is about the same, then this probably more chronic process does not need further inpatient evaluation. The other ones, I think you really need another data point. I think it would be challenging to say someone has an AKI and you don't know the trajectory. Is it getting worse, getting better, or staying the same to discharge them, unless it is a patient that you feel confident about the follow-up plan that can come for blood work the next day in the outpatient side. And so I don't want to, blanket statement say that this is, absolute admission that as soon as you the creatinine up, you hit the admit button. I don't think that is the case. I think it is, as everything, patient specific, but there needs to be close follow-up, I think, regardless of what the etiology is.
Great. All right. Well, thank you.